Hey, good morning, everybody. My name is Catherine Belunas Hernandez. I am the cardiovascular thoracic surgery nurse navigator for Ascension Providence in Waco, Texas. Thanks for having me today. And we're going to talk about patient education and what it's done for my patients since we have effectively introduced this new way to educate our patients pre and post-operatively. I don't have anything to disclose, and before I start, I do need to say thank you to these wonderful people up here. Dr. Jeffrey Young is my surgeon. He's amazing. He listens to all my harebrained ideas, and of course, my PAs, David Fickett and Joshua Flores. My leaders, Dr. Kevin Stevenson and Laura Lee Hogue, along with Bellum. Dr. Samina Ali, who runs our TAVR program. Mackenzie Adams, my professor, Leona Gamrell. She taught me nurses educate first. And then, of course, my boys, Private First Class, William Belunas Cloppy, United States Marine Corps, Christian Belunas Cloppy, and Orion Belunas Hernandez. I wouldn't be a nurse if it weren't for those three. So, patient education and open heart surgery. We all know, as nurses, how important it is to educate our patients. But the problem is if you listen to the nurses on the floor, everything is different. Everyone teaches differently, there's different jargons, and we all say things just differently. I created a structured patient book so that the nurses could see this, see what the patients are to expect, and they would also start using the same language so that there was a consistency throughout and not so many questions for patients, so they would get the same message. So the impact that we had, it was just the structured patient education, particularly through the use of that patient journey book that I created, and it enhanced their comprehension and engagement. And it correlated with our outcomes, which was outstanding. I'm going to show you a whole bunch of graphs later on in our statistics. This presentation is going to analyze the metrics and demonstrate the positive effects that this patient journey booklet has had. So development. Unfortunately, I'm going to call my hospital out a little bit. When I first started working, I already knew what the challenges were for education before patients went home because I was the supervisor on our step-down unit. So I was familiar with how the nurses spoke and things like that, but I wanted to look at what they got pre-operatively. And so I started digging around and I started asking my surgeon questions and I asked his office questions and said, hey, what do we do pre-operatively for these patients? They had one sheet of paper that had the surgeon's name, where they were having surgery, the date, and then it had 4 different instructions. One of them saying, just take all of your heart medications in the morning, which is not a great idea for patients because they mix all that up, and then to call if they have a fever. That was all the education they got, besides talking with the surgeon at that one meeting before open heart surgery, or if they were in the hospital, they really got just the, hey, this is what's going on, every time the surgeon would come see them, and that's it. So I created that book, and it has different sections, and biggest thing is it has surgical procedure insights, and these are in the very beginning of the book, and it talks about, hey, this is what your open heart surgery is, this is what a STEMI is, an NSTEMI, all that very normal small terms that we are used to that patients aren't used to. It's helping getting them used to our jargon so they can kind of connect more. And then it's got post-op recovery expectations, and then, of course, their lifestyle changes that we need to implement. Biggest component is when I see these patients pre-operatively, and I do see every single heart, every single one of our patients, I see pre-operatively and post-operatively and follow-up calls with them. We talk about pain control because people for some reason think if they take pain meds, they're going to get addicted to them. And I really stress to them that that's not how this works in this situation. And so we usually have a long conversation about that and asking for pain meds. Having that has helped reduce our AFib instance. It's helped control their pain. They're ambulating more. They're getting up more. Nutrition has also been something that I teach them about, simply because they get their Juven, and I'm the queen of Juven, y'all. I love Juven. They get their Juven, and then they get their protein shake, and they're like, I don't want this. I don't know what this is for. Why do I have to have this? So we have a conversation about that too, and there's very good compliance afterwards once they understand. And then, of course, their activity goals. They think they're going to lay around in bed, and they are very shocked when I say, nope, we're sitting up on the side of the bed after 6 hours after surgery. And they look at me and they're like, no, really? And I'm like, yes, really. So those are all things that they start getting in their head beforehand. So distribution and accessibility. We have a multimodal distribution approach. So the nurse practitioners see the patients in the clinic and beforehand, and they let me know about these patients. If there's somebody I need to come talk to and go see them, kind of give them more information, I go see them. And otherwise, I see them here in the hospital, talk to them, and I give them their books. The nurse practitioners also gives them their books. They get personal education with me every single day. I don't have a set schedule with them. I go in, I say, hey, this is what's going on. What kind of questions do you have? What concerns do you have? And they tell me. And so then it doesn't matter. I could be in there 45 minutes. I could be there in 10 minutes. It's whatever that patient and that family and the caregivers need. And then I get continuous feedback from them. So the impact, this is what everybody really wants to know. So of course, we have enhanced patient empowerment. We have our visual learning tools because everything is written down, and then of course the feedback is driven for improvements. I'm consistently improving the book and improving our program through their insights. We have a reduction in postoperative anxiety. It's night and day difference for these patients once they have talked to me and they've been educated. So, enhanced postoperative compliance, that's the hard part. Getting people to use incentive spirometers instead of them thinking, hey, this is a toy, this is what this is for. They understand more. We give them gum afterwards to prevent ileuses. They understand that. They take a bigger role in their self-care, and then of course, they are monitoring and feeding me back information about their care so that we can adjust for them. Staff training is always the hardest part of everything. It takes about 6 months just to train the nursing staff. And then I also, since CV is a team sport, have to think about my PT, OT, dietary, and all of the others that are included in this patient care. So the nurses now have a comprehensive role for understanding and taking care of these patients. We also have interdisciplinary collaboration skills. So they're working with the other departments, with PT, OT, so that we can all have a unified front on how to take care of these patients so it's consistent. And that's just more about it. That's just the patient text. Importance. So enhanced interprofessional communication. That way a nurse can say to a doctor, this is what I'm seeing, they're not ambulating, they're having these issues, we can get them to a rehab quicker and easier because we're able to communicate that. So it's decreasing our length of stay and increasing the patients getting out so that we have better money, get more money, and they are happier. Holistic patient management, I love when it's complete. I feel like patient management should be a complete circle and no missing pieces. And so we have included everybody in there. It's not just doctors and nurses working together. It is dietary, it's PTOT, it's speech. All of us are all connected together to come for these patients. And then of course we have continuous quality improvement. This is the part everybody wants to know about, our outcomes. So we have a huge reduction in mortality rates, and I'm very proud of this year's especially. In 2022, when I took over in October, we had a mortality rate of 2.34%. That to me was too much. I think that, one death is too much. Now, these are sick patients sometimes, and there are those patients who we try our absolute everything, and we cannot do anything about it. That is not that it's okay, but it is an easier acceptance for me than seeing a patient who we should have had in our safety net sooner. So we went from 2.34% in 2022, and now we're at 0. So I'm very, very proud of that fact. And that is simply just from educating our patients, having that knowledge given to them because they are more compliant. There's a marked decrease in ICU delirium, and then post-op infections, which have been included like pneumonia, sternal infections, all of that has decreased and is 0. So this is our CABG mortality rate. This is CMS data. We were at 1.47. As you can see, where I really started, this is at that 1.47. That's when my book was approved by Ascension, and I started printing it before marketing had it, and I started handing it out at that point. And you can see it drop and drop and drop as I taught these patients. So this is just reaffirming that. You see our mortality rate is now 0, And then everybody knows that we had a data breach with Ascension, okay? The nice thing is, the miraculous, wonderful thing about my team is even when we had that data breach, all of our order sets were gone. Thank goodness I have copies. But everything was gone, and those patients still received the exact same care. Think about how phenomenal that is. My team knew exactly what to do, and they received that exact same care. That is a huge accomplishment on their part. So, this is our 2023. You see all my red. Lots of improvements we needed. Lots of things we worked on. We had a lot of prolonged vents. We had strokes. We had AKIs. All of that stuff. Nothing I like up there. This is 2024's. Much nicer. And the two prolonged vents that we had up there, those were patients we knew were going to have trouble with the vent. Their lungs were just not great from smoking for so long. So we knew that was going to happen. So to me, this entire thing is green. All right? Big difference right there. Shorter hospital stays and quicker recovery is one of the biggest things that people ask me about, and that it does happen. It's a combination of having that proper nutrition for the patients and teaching them exercises preoperatively and continuing to reinforce that postoperatively. So they are more ambulatory and they stay strong rather than sitting there in the chair or in bed and getting weaker. So in conclusion, the implementation of the patient journey booklet has led to notable enhancements in patient outcomes, including reduced operative mortality rates, improved patient understanding and engagement, decreased incidence of ICU delirium, and increased compliance with postoperative care. Ultimately, it is resulting in fewer complications and shorter hospital stays. So recommendations I have for my future things that I'm going to continue working on are obviously regular material updates because we want our practice to continue to grow. We're going to try and do digital tools at some point, and then we're going to keep doing interdisciplinary education initiatives so that everybody is on that same page still. Language barriers is a big thing for me because a lot of my patients actually speak Spanish, and it bothers me to a great degree when I walk in and I cannot hand any written education to my Spanish-speaking patients, and we've had some Mandarin and other languages. It bothers me. So right now I'm working on getting a written booklet just like I have for my English speakers, for my Spanish speakers, and then once that's done, we are translating it into any other language that we have available at Ascension, and it will be loaded onto our intranet so that anyone across Ascension can actually access this book and print it in any language. And then from that point, we'll change it into a QR code, and then that way people will have a digital access and they will also have their written copy. Thank you.
Anyone have any questions? I like the Juven. We've been using Juven more for pressure injuries.
Mm-hmm. A lot of people do that.
Yeah, so we've been using it more for if you have a brain less than 15, that we're starting Juven in our ICU, but we haven't used Juven for like that SSI prior to surgery or optimization of nutrition.
Oh, absolutely. We absolutely use it just because it helps them heal up to 2 weeks faster. So we have seen excellent results with that, especially with like my diabetics. We've had bilateral nephrectomy patients, our kidney patients, all of our dialysis patients. They do outstanding with it. And so we give it to everybody. I mean, it's like Oprah. I'm like, you get Juven, and you get Juven, and you get Juven. Everybody gets Juven, okay? Everyone.
Yeah, no, that's awesome. We gotta start using Juven more.
Yes.
Thank you.
Thank you.
Okay. Well, I'm going to. So our next presenter is Marcelina Victory Stewart, and she's going to go over Nursing Excellence and Beacon Awards in Cardiac Surgery ICU. Our journey.
Well, you know this journey. Oh, you all know who I am. But before I begin, I want to give a big shout out to Mallory, who did who is my partner in our journey from bronze to beacon, and who couldn't be here today but was very instrumental in putting all these PowerPoints together for us today. I wish he was here. So today I'm going to talk about our introduction into the Beacon Award for Excellence, a little bit about the Mount Sinai Fuse to Heart cardiac surgery, our journey from Beacon Bronze to Silver, some of the strategies that we use to achieve Beacon Silver based on the recommendations of our Bronze outcomes, strengthening evidence-based practices, enhancing those clinical outcomes, getting the staff better engaged in continuous improvement, and our next steps towards achieving the Silver Beacon Award. So what is the Beacon Award? The American Association for Critical Care Nurses Beacon Award for Excellence is a prestigious recognition awarded to units that demonstrate excellence in nursing care, leadership, and patient outcomes. It highlights the efforts of hospital units that have made significant improvements in patient care and provide an environment conducive to optimal patient outcomes. The award is given for 3 years, after which units can reapply to maintain their status or achieve a higher goal. Some of the criteria is based on 6 main categories, and that's leadership, structure, and systems. Effective leadership promotes good quality care. Appropriate staffing and staff engagement. We have to ensure that we have adequate staffing levels and high staff engagement. Effective communication, knowledge management, and learning. These promote continuous learning and ensuring communication and knowledge is shared within the unit. Evidence-based practices and processes, incorporation of the latest evidence-based practices into patient care. And of course, outcome measurements. Our data demonstrates that we have improved outcomes, including clinical outcomes and patient satisfaction and safety. And finally, we have a healthy work environment. Establishing a healthy, supportive environment promotes better care for our patients. There are 3 levels to the Beacon Award. Starting at the bottom is the bronze, which shows significance towards excellence. The silver is exceptional care through improved outcomes, and obviously the gold is the highest in maintaining those levels. Here in the UK, though, they don't have a comparable, they don't have a Beacon Award, but there are a few distinct awards that are comparable to the same focuses that we have for the Beacon Award. These are the Nursing Times Award, the Royal College of Nursing Award, the Health Service Journal Awards, and the Florence Nightingale Foundation Leadership Scholarship. A quick overview of our cardiac surgery ICU. So 6 East is or Morningside is a non-for-profit community teaching hospital acclaimed for excellence in clinical quality care. Mount Sinai Fuse to Heart at Morningside provides world-class patient care to the diversified urban communities of the Upper West Side, Harlem, and Morningside Heights. Mount Sinai Fuse to Heart at Morningside is a distinguished hospital program for unrivaled diagnostics, curative measures designed to identify, treat, and prevent heart disease. I sound like Beth Oliver. Through the collaboration between the cardiology program and the cardiac surgery program, Mount Sinai Fuse to Heart at Morningside has expanded to great lengths. The United States News Best Ranking has designated Mount Sinai Fuse to Heart at number 16. The Mount Sinai Heart Division also possesses a 3-star CABG rating from the Society of Thoracic Surgeons and has earned gold recognition for STEMI, non-STEMI, and heart failure through the American Heart Association's Get With The Guidelines program. 6 East has 2 units combined into 1. It's a 26-bed unit in total. 11 beds are dedicated to cardiac surgery. 15 of that is in cardiac ICU. Our unit is also a primary stroke center, designated a primary stroke center by the Joint Commission. So our journey began in achieving bronze in 2020. As a team, we felt invigorated by this distinction to showcase our key achievements in the development of patient-centered care model, implementation of safety protocols, and patient care guidelines, and the quality of care we deliver to our patients. With our next application submission, we set higher goals, setting our goals for silver. After we received the feedback from the American Critical Care Nurses, we set to improve metrics in quality outcomes, establish professional development and recognition programs, and foster a culture of shared governance and innovation. Some of the key strategies that we use to obtain the silver status were strengthen our evidence-based practice through utilizing our CABG pathway more efficiently, enhance clinical outcomes such as surgical site infection, improve nursing quality indicators, and finally broaden our staff engagement through the development of our unit practice council. We worked on our CABG pathway first. The CABG pathway are specific interventions geared towards post-operative days. By achieving these daily goals, we aim to increase mobility, decrease pain, initiate nutrition, right? Very important stuff, decrease length of stay, and increase patient satisfaction. We recognized that we needed to include preoperative interventions alongside intraoperative improvements and postoperative enhancements. We have preoperative updates. The original pathway was missing an entire preoperative component, so we set up a preoperative workup to be included. This included risk stratification tools such as the STS scoring, CHADVAS score, and it also included key reminders such as avoiding specific medications, strict glucose control, and extensive pre-op education for our patients. Intraoperative improvements included the standardization use of antiarrhythmics such as amiodarone to reduce atrial fibrillation risk, preemptively reducing pain by utilizing other agents, thus reducing narcotic use postoperatively. And postoperative enhancements also included a focus on recovery protocols like multinodal pain management, promoting early extubation in our off-pump CABGs, early ambulation, and strengthening infection surveillance and prevention measures. So our CABG 2.0 has resulted in improved recovery times, decreased complication rates, and improved patient experience scores and cost savings. We decrease our average length of stay up to 20% by improving ICU capacity and resource utilization. We lowered postoperative complications by 30%, such as complications of AFib, infections, and blood clots. We improved recovery times with our fast-track extubation, early ambulation, and overall recovery speed that reduced the length of stay. We had improved patient outcomes, improved surgical success rates, and patient safety. Patients reported better management of their pain. We were able to ambulate them much more quickly, and an overall positive experience. All of this reduces the costs by reducing complications. We had shorter ICU stays and more efficient discharge planning with improved team efficiency. We enhanced our clinical outcomes through our reduction of surgical site infection. It was a multidisciplinary approach. This approach involved reviewing compliance with surgical site protocols, optimizing glucose control, and enhancing patient education. Antibiotic therapy played a pivotal role, with the first dose being administered prior to skin incision during the intraoperative phases. The 60s multidisciplinary team worked very closely to successfully minimize the risk of SSI during hospitalization and well after discharge. The SSI rate from 2017 to 2022 was significantly lower at 0.19% compared to the national benchmark of 1. We worked hard on that, right, Shauna? We also had a CAUTI bundle for preventing catheter-associated urinary tract infection through evidence-based practices, including strict adherence to sterile technique during catheter insertion and maintenance, Key components also emphasize timely removal of catheters. I can't tell you how many nurses love to keep a catheter in because they just got their Lasix. And then we had questions on rounds, do we actually need the catheter? Routine assessment, making sure that the catheters were adhered to the leg and not bundled up and causing backup of urine. And of course, comprehensive staff and patient education. As you can see by these numbers, that 6 East, the national benchmark is 1.6, and 6 East has maintained from quarter 2 of 2021 through quarter 2023, 0. And we continue our journey is to maintain that. Our central line infection rate, you can see that from 2021 to 2023, we had 0 incidents except for a small bump in quarter 3 and in 2021 and in quarter 3 in 2022. The nurses understand the risk for infection is higher the longer a patient has a central line. As part of all of our pathways, the nurses discuss on rounds the need for a central line. We understand that some patients require a central line is the only option. But the CLABSI Bundle Institute is designed to promoting strict adherence to sterile technique insertion and proper maintenance of central lines. Core elements include using maximum barrier precautions, making sure that the dressings remain intact even when the patient is out of bed. The daily assessment, of course, of the necessity of the line, ensuring prompt removal, and making sure that the lines are labeled and the hubs are all capped to prevent further infection. We used our unit-based practice council was part of what we used to promote staff engagement. By doing this, we, helped the staff to use evidence-based practice. We recognized and rewarded their exemplary work. We had quality improvement initiatives, and all of this helped get the staff involved in the processes of the unit. Through this, we developed a virtual comment box where the patients, the nurses scanned and anonymously entered positive or negative comments about the unit and worked on improving or working through all those. We had a broken equipment pathway, a rapid response EEG proposal project, an assignment tracker project. These are all the things that the nurses wanted to work on, as well as a supply conservation project. One of the projects that we did work on was the broken equipment that was scattered all over the unit. It wasn't getting repaired in a timely fashion, so we had to designate an area in which to place the equipment, tag it, send it to a biomed in a timely fashion, and then, of course, get their equipment back to the unit in a timely fashion. So what were our next steps in order to achieve silver? So we prepared an application, we submitted this, we remained hopeful, crossed our fingers, and we waited. That wait was really, really long, correct? And then finally, in 2024, we were awarded the Beacon Silver. We kept that a secret for a while too. But the team was very excited to win this. So what is our future goals from here? Well, obviously it's to maintain this excellence. We want to try to improve and get to, well, not try, but we will improve to get to gold. We've identified areas that need improvement. Right now we're working on different quality measures such as pressure injuries. And our long-term goal is to achieve Beacon Gold. So then the next, 2026 is our next application. And that's it. Thank you.
So it's no longer going to be a 3-year application. You have to get redesignated every year. The application is no longer going to be a 50-page document. It has 3 categories, and in those 3 categories, there's 3 subcategories, and they're going to have more focus on quality metrics than actual writing a document. The previous Beacon document was, like I said, 50 pages, and quality metrics was just a piece of that, and a lot of it was writing. And now they're removing it all away to really focus on quality metrics. The unit should have probably got gold because we, like you saw, our pressure injury prevalence was 0 for 8 rolling quarters. CLABSI was only, we had two, but we had 6 out of the 8 rolling quarters for NQNDI, and quarter you can see that we had 8 quarters of nothing, and actually that is the requirement for magnets. So if you have 6 out of the 8 rolling quarters, you've met metrics for a magnet. So it was a little kind of like, why didn't we get gold? But next year. Our next. Yeah. Yeah. But that's why they're focusing more this year on metrics alone and not all the other verbiage. So it's my pleasure to announce Ami Shah, who is our pharmacist, who's going to go over AFib management.
Thank you, Shauna. I think I know most of you, but my name is Ami, board-certified clinical care pharmacist, currently serving as medical director in pulmonology at VMedi. Today I'll be discussing postoperative AFib, as Shauna mentioned, in patients undergoing CABG, and I have no disclosures to report. The objectives of today, we're going to analyze key trends and incidence, risk factors, and long-term complications. We're going to compare current guidelines to those international recommendations and evaluate some improvement opportunities. And then lastly, we're going to evaluate gaps across the spectrum of perioperative phases and discuss future recommendations for enhanced patient outcomes. So postoperative AFib, as we'll refer to it as POAF throughout the presentation, but the STS defines it as new onset post-surgical AFib that lasts for more than 1 hour and or requires treatment. It's obviously the most common, as many of you know, the most common complication after cardiac surgery, and it occurs in approximately 20 to 50% of patients. Now, this graph that's here for you kind of lists different types of procedures from left to right, isolated CABG, then univalvular, and then as we get into more complicated CABG plus valvular or multivalvular, the incidence of that post-op AFib increases. We know the risk and that it exists for these patients, but I think it's important to also discuss what is the impact of these risks on long-term outcomes. And so that's what this slide is showing you. There was a meta-analysis done with over 150,000 patients, and it showed that post-op AFib incidence is directly linked to higher mortality. And so that hazards ratio shows that there's a 25% more likelihood of mortality in these patients. This last year in 2024, there was also, it's called the Sweetheart Registry, but it was patients in Sweden, and they did a very similar study. They looked at 30,000 patients in Sweden undergoing CABG, and they looked in the middle, you'll see different cohorts. So we have on the top patients that experience post-op AFib, and then on the bottom section of that middle portion, patients that did not experience post-op AFib. And the outcomes all the way on the right, you're seeing that all of these patients, they did a median follow-up for almost 5 years, and they showed a significantly higher increase of recurrent AFib, chronic kidney disease, heart failure, and similar to the last study we just looked at, increased mortality of all-cause and both CV mortality. So now we're talking about these long-term outcomes, we're talking about the risk factors, but at the end of the day, we have to evaluate, are all patients at the same risk, or are there some patients that are at higher risk than others? And so that brings me to my next slide. There's 3 major categories for this. And so the top, we'll see pre-existing risk factors, and that includes things like age, obesity, genetics. On the left-hand side, we'll see surgery-related factors, so including cross-clamp time, and as we talked about, different types of procedures have different types of risk. And on the right, we'll see post-op factors. As we talk about different risk factors, I think it's important that we talk about scoring algorithms. There's been different and numerous amounts of scoring algorithms to determine, is there a way to stratify the risk of post-op AFib for these different patients? The first one is the post-op AFib score. There's a little bit of details recommended there, but they include if someone had a pre-op intraoperative balloon pump, if it was an emergency surgery, or if the EF was reduced. We then have the CHADS-2 VASC, which is something that's widely used, but it incorporates heart failure, hypertension, age, diabetes, and the rest of the CHADS VASC criteria. But the one thing I'll highlight is really what's on the bottom, and that's there's been over 12 prediction models for post-op AFib, and there was recently a very well-conducted meta-analysis in 2023. And it essentially showed that all these risk factors that we talked about, the one that was most important was patient age. And that brings me to our next topic. Why are we discussing this today? And essentially, it's these 2 bullet points. The first one is that despite decades of improvement in cardiac surgery, the risk of post-op AFib remains the same. However, the prevalence of these risk factors, especially age, as we talk about age, is only increasing for our patients. So what are we doing about it and how can we improve? The second bullet point is that there's been new guidelines. So in 2023, which is essentially the end of 2023, so almost 2024, there's been new US guidelines for what to do for AFib patients. And then in 2024, there was also new European guidelines. So what we're going to do today is kind of review some of those guidelines specifically for the US, but then also start comparing them across international countries to see where are they the same and where do they differ. So as I mentioned, the 2023 US guidelines for AFib is something we're going to kind of spend some time on. This slide is not meant for you to read, but it's more so just to depict that anytime we talk about guidelines, there's always going to be a class of recommendation and then a strength of that recommendation. So on the left-hand side, you'll see a bunch of colors. What I'll point out really here is that green represents class 1, and that's the strongest class of recommendation that you can have. Yellow is intermediate class 2. And on the right-hand side, you'll see a bunch of blue, and that's the level of evidence. How strong is the quality of evidence that supports these recommendations? Because as we know, a lot of cardiac surgery doesn't really have a lot of literature available that's consistent to give these recommendations. So the point of this slide is really to say, as we talk about recommendations, I'll tell you how strong that recommendation was in these guidelines. This is a very busy slide, but what I want you to take away from this slide is that this is the first time in the US guidelines that AFib has been discussed in different stages. In the past, it was previously you either had AFib or you didn't. This is the first time from left to right we're seeing stage 1 to stage 4. So stage 1, we're seeing, are you at risk for AFib? And that kind of comes to those risk factors that we were talking about. Stage 2 is what we consider pre-AFib. Again, first time we're ever hearing this terminology, and this is kind of important of why we're discussing this today. So everyone's aware of these new guidelines and what this new staging system is. Stage 3 is what they consider AFib, and it has different subtypes. So that big arrow, it goes from paroxysmal AFib, pre-existing AFib, to long-standing AFib, and then if you've had an AFib ablation. And then stage 4 is essentially permanent AFib. And the recommendations of what you do for each is listed on the bottom, but the one thing I'll highlight is that the reason that we have now these stages and this new continuum of disease is that we start thinking about it earlier. We start looking at risk factors and start thinking about pre-AFib. Who's at risk for this? How do we manage that risk? Rather than just waiting for them to have AFib to discuss treatment or no treatment. So now as we talk about the guideline recommendations, we have perioperative management for AFib. And so this is the US guidelines first, and we have two main recommendations. They're both in yellow, which represents it's a class 2, as we talked about previously. And so on the left, we have patients at high risk for post-op AFib should receive short-term prophylactic beta blockers or amiodarone. We'll talk about that verbiage in a little bit, but that's what we're seeing here as the recommendation for the new US guidelines. And then on the right, we have patients specifically getting procedures listed here should receive a left pericardiotomy. These are patients who have not previously had AFib, but just are at risk of AFib. Now we have one more recommendation here, class 1, which is the green, saying that patients who have AFib and are at high risk should also be considered for a left atrial appendage occlusion. Now, you'll see this type of slide pretty often throughout this presentation, but what this slide is doing is that it's putting all 4 of the main international guidelines from left to right. So on the first column, we have the US guidelines. The second column, we have those new European guidelines. The third column, we have the cardiac anesthesia, also European guidelines. And then the fourth is the Canadian guidelines. And so this is just to start comparing what these recommendations are. On the left, we have the recommendation. So this is for preoperative beta blocker and perioperative amiodarone. As we talked about, the US guideline gave both of them that yellow class 2 recommendation. As we compare internationally, a lot of them are either class 1 or class 2. And so we'll talk a little bit about this, what this means. And I think kind of as Shauna and Marcy already mentioned in their presentations, we've recently adopted amiodarone into our protocol, but with these strong recommendations, there's several programs throughout the country that still don't have a standard program. And so I think it's important to start looking at these recommendations and start thinking about, are we with the guidelines or where are we behind and where can we improve? Intraoperative management, there's been 2 recent new recommendations, which we already talked about for the US guidelines, but here's for comparison. The pericardiotomy was class 2 for us, also class 2 for Europe. And then the left atrial appendage for patients who already had pre-existing AFib in combination with anticoagulation. Class 1 for us, which is improved from a class 2 in the last version of the guidelines in 2019, and then also class 1 in Europe. So where are the gaps? Now that we've talked about US versus international, where are the gaps? And this is where we'll start talking about some of that terminology that we mentioned. There is a little bit of variation in the recommendations. We talked about surgical type very early on in our presentation, but nowhere in these guidelines do they define what to do for an isolated CABG, an off-pump CABG versus a CABG plus valve. It's unclear of when exactly to initiate. We use some things like perioperative verbiage, but what exactly does that mean? When can we give preoperative beta blocker versus preoperative amiodarone? Not really clearly defined in the guidelines. The dosing regimens are not defined, and that becomes a wide variation. And then there's also non-standard definitions. What does it mean to be high risk? What does it mean to give short-term treatment? And so that's where I think a lot of programs differ. The next phase that we'll talk about now that we're done talking about preoperative and prophylaxis is treatment. So what you're looking at here is the US guidelines. We're going to start at the top. So first we have AFib after cardiac surgery. In green, you see, which is a class 1 recommendation, rate control with either a beta blocker or a calcium channel blocker. They don't differentiate between the two. Consider anticoagulation when deemed safe from surgical bleeding. Again, a little bit variable and up to surgeon preference or provider preference. If it's hemodynamically stable, they recommend either rate control or rhythm control, both in green, and they don't differentiate. If a patient's hemodynamically unstable on the other side of that arrow, a level 1 green recommendation for direct cardioversion. And then in terms of rhythm assessment, reassess in 30 to 60 days and cardioversion if it's not converted to sinus. Okay, so same thing as before. We're going to compare it across the groups. We'll start with the first, which is beta blocker for rate control, class 1 across the board, which I think is pretty standard for our patients. The second is calcium channel blocker for rate control. Some have class 1, others have class 2. And then lastly, we have hemodynamic instability cardioversion, also usually class 1, and then for the Canadian guidelines all the way on the right, it's second line, whereas first line is rate control with beta blocker. Same thing here, we're going to look first, a symptomatic patient, the US guidelines said to do cardioversion to restore sinus rhythm, class 2 recommendation across the board. Asymptomatic AFib, rate control and anticoagulation. I won't read that to you, but it's here for your reference. And then lastly, we have anticoagulation, considering their individual risk. Class 2 across the board. The only one slight difference is that the US guidelines say that the follow-up of when to reevaluate if a patient still needs that anticoagulation is 60 days, whereas the Canadian guidelines say 6 to 12 weeks. But strong recommendation across the board. So one more time, what are the gaps here? In that phase, there really weren't that many, but the few that I'll point out is that when exactly are we initiating the beta blocker? I think it's standard practice, and it's been a quality recommendation from the National Quality Forum to do 24 hours within CABG, but there's also a little bit of variation there, depending on how frequently we're looking at these patients. The meta-analysis have interestingly grouped preoperative, intraoperative, and postoperative all together. So the utility of preoperative beta blockade is not as clear. The beta blocker choice is also different depending on what country you're in. So there's a little bit of data between carvedilol and metoprolol. And then the difference between rate and rhythm control is also kind of variable internationally. So there's varying practice patterns there and not that many randomized control trials to help us decide which one to use when. All right, so we're moving into summary of recommendations. We talked about a lot of different guidelines, so where does that leave us in terms of what to do for our patients? This is a very busy slide. I won't be reading all of it to you, but essentially it breaks from the left side, it breaks down the phase of care. So we see preoperative, intraoperative, postoperative. The middle is all the recommendations we've talked about. And on the right-hand side, we have X's determine if it was in at least one guideline or a majority of those guidelines to determine what we should be doing for our patients. This is really here for your reference, but it just kind of incorporates everything we talked about. The one I will highlight to you is preoperative, which is really the most variable that we've seen in the guidelines. So we have an oral beta blocker. By a show of hands, how many people are using a beta blocker preoperatively for patients? Is it routine for all patients? And then how about amiodarone? Yeah, so I saw almost everyone routinely kind of shake their heads, like some yes, some kind of maybe. And so I think that, like we said, there's a little bit of variation and that needs to be discussed, and that's kind of why we're here today to discuss if it's such a strong recommendation, where is this coming from? All right, so another quicker summary of recommendations. So on the left, we have preoperative. We talked about beta blockers, we talked about screening tools, and we talked about surgical plans. By a show of hands also, how many people are using a routine stratification tool? I see Shauna nodding your head, and I assume we're still using CHADS-VASc. Is that the same for you? What are you using? You're using CHADS-VASc for your patients? Wonderful. Okay, intraoperatively, we have the pericardiectomy that was mentioned. Postoperatively, the meds that we talked about, pacing, electrolyte repletion, and the one I thought was most interesting as we start thinking about this is future technologies. Who should be wearing real-time monitors to determine if they develop AFib or not? And then clinical decision support, which I think falls a large part into determining how we can standardize our care. Okay, so future directions. First, we'll talk about guideline adherence. These guidelines, I think, are pretty, although there's a little bit of variation between different guidelines, relatively they have strong recommendations. And so what is our adherence to some of these things? Secondly, among the gaps that we found, how do we address those gaps? And then third, what are some ongoing studies and additional interventions that are being evaluated? So this was a study that was done in the UK. They took 31 centers, and this big pie chart essentially is telling you what's on the bottom. How many people are following the recommendations for AFib, and where are their recommendations coming from? So I think first off, we should highlight that everyone kind of had different answers on if we're even using amiodarone or not. And then secondly, when we start thinking about how are we using amiodarone, which guideline are we using for the recommendations, especially because the guidelines are also a little bit vague on when to start, what dose to give, how long to give. It's interesting to look at some of this information. So the biggest portion, which is the 35% here, actually say that they're not even doing amiodarone in the UK. 26% is just local guidance. There's others that are the European guidelines. There's others that are the UK guidelines. And so the point here is that you see a wide variation. What they did find is that the most common interventions kind of aligned with what you had already mentioned. What are the most common interventions? One is beta blocker, which I think we said we use routinely for everyone. Second is magnesium supplements, and then potassium supplements. Now, this slide is also busy, but the reason I highlight it is because I think we already established that we're using beta blockers across the board. It's a quality metric to use in 24 hours after CABG, but I think we also can recognize that there's a lot of our patients that have other reasons that for some reason we can't do the beta blocker, whether it's hypotension, something else, some reason that we can't initiate it right away. And so what this slide is showing is that there was a study that was done that focused just on quality improvement, and they were looking to see when are we actually starting that beta blocker. And so that gray that you see, I won't highlight everything to you, but what I will highlight is the gray. The gray represents day 5. Red represents day 4. Blue highlights day 3, and so on. So the black is actually day 1, which is the recommendation. And as you see throughout from the as we go from October to December, throughout that time, what they did was really focus on when are we starting this beta blocker. And as you see over time, they reduced the gray, which is essentially we're starting it earlier when we need to. So on average, what would you say, given all the considerations for our patient, what is actually the day that we start beta blockers? What would be your average in your practice? Day 1. Shauna, what about you? Day 2 or 3. So it's interesting to see that if something has and beta blockers is the one thing we agree on. We're not even at amiodarone yet. And so it's interesting to see that there are some variances, and so it's important to start thinking about how can we start aligning with the guidelines and then let alone start addressing some of those gaps. So the first thing I wanted to highlight here, what can we do to improve that guideline adherence? And I think there's 3 parts. One is starting to risk stratify these patients. I know CHA2DS2-VASc specifically at Mount Sinai has been a relatively new concept, but it needs to be nationwide. And so that's really the call to action here. Start risk stratifying your patients because this is a spectrum of disease. It's no longer just waiting to have AFib or not AFib. And then the second would be starting to focus on earlier post-op AFib management. We'll talk about turnkey order sets in a moment, but just to kind of highlight that earlier post-op AFib management, this was a study that was done looking at over 1,000 patients, and from left to right, they looked only at patients who had no history of AFib. On the left, if you had no history or no early post-op AFib, you also had a less likely chance to develop future AFib. In the middle, if you had post-op AFib for less than 48 hours of a duration, you had a higher risk in yellow of determining if you have recurrent AFib in the future. And then interestingly on the right, if you had post-op AFib over 100 patients for more than 48 hours, this essentially showed that you were 6 times more at risk for developing late-stage AFib. So managing, the point of this is that managing post-op AFib before it exceeds that 48 hours is incredibly important to reducing post-op AFib reoccurrence in the future. What I also thought was interesting was that in this study, they also looked to see, does a surgery type, the left atrium size, the CHA2DS2-VASc, do any of those things matter in the fact that they develop recurrent AFib? And it wasn't. It was simply that their duration of AFib was more than 48 hours, and that itself was a 6-fold increase of having late-stage AFib. So we talked a little bit about this turnkey order set implementation. So this was a result of the ERAS implementation group, and I will highlight that one of our co-founders, Dr. Puskas on the other side, was part of developing this order set, and he was one of the authors of this paper. What they did was create a standardized order set. We talked about how there's nationwide differences, let alone international differences. And so what they did was develop a standardized order set that could be implemented across different health systems. This is going to be a very busy slide, but I do think it's worth spending some time here. And so for preoperative use, they recommended if you're currently on a beta blocker to continue, which I think is standard practice. If you're beta blocker naive, still give a dose of beta blocker right before surgery. Amiodarone, as we talked about, is here. So they recommended stratifying using CHADS-VASc, and then considering an amiodarone dose listed here, which I think, again, there's a little bit of difference in terms of how each center practices, but that I think is a highlight of making sure that we're risk stratifying our patients and using preoperative management to reduce the risk rather than waiting for AFib to happen. And then intraoperative, as we mentioned, consider posterior pericardiotomy at the time of surgery. I won't read all of this to you, but they did the same thing for postoperative and follow-up of what to do and to make sure that this order set is being implemented across the country. So now addressing gaps in care, just as a summary. I think we need a little bit, as we talked about, there's Canadian guidelines, European guidelines, American guidelines. So what are the gaps? How do we bridge that gap between? Quality improvement initiatives, as we talked about, something as simple as beta blockers, just really focusing on one at a time and making sure that we're, throughout time, looking and tracking our metrics to see what we can do to better get with the guidelines and improve standardization. Standardizing a risk stratification tool. So I think you both mentioned that you're using CHADS-VASc, so just out of curiosity, what is your baseline of what is considered a high CHADS-VASc versus not? When would you treat post-op AFib, or when would you consider someone at high risk of post-op AFib? I'm gonna let either one of you answer. Yeah, either Sean or whichever.
I let the doctors decide that, so.
Oh, I see Layla in the back. We could ask Layla.
We don't use the score to determine. We kind of just universally will treat everyone. It's all surgeon-based. Some will start everyone on amiodarone post-op. Some will only do it if we start. I mean, it's so diverse. The practices. So we don't use the score to determine who we're going to treat preemptively.
So I'm so happy we've had this conversation, but even with the group that we have here, it's interesting to see how much variation exists. And if we even think about nationwide or even start thinking about internationally, the fact that I think we were mentioning earlier that these are all class 1 recommendations and all of the new US guidelines, the new European guidelines, and even the Canadian guidelines. So it's interesting to see that we're still behind the time and kind of catching up with what these guideline recommendations are. And that's kind of the point of addressing these gaps in care. So now to move into some additional studies, this is just kind of FYI so you know what's on the horizon of what's coming. There's new studies. For example, the first one is a new prediction model. I think we all mentioned CHADS-VASc, but there's also something called the Delphi process, and it's part of a much larger study called the Paradise study, and it's using machine learning to start determining prediction models, because we talked about CHADS-VASc, and we all know that CHADS-VASc is limited by 5 or 6 variables, and we talked about how there were many other risk factors beyond that, and so this machine learning is supposed to help determine a better prediction model for who's at risk for AFib and who's not. Second, we have an agent called Landiolol. It's very common and it's been used in Europe for over 20 years. It recently got FDA approval for just atrial tachyarrhythmias in critical care, but there's a new trial called the FACC trial specifically in post-op AFib. And then interestingly, there's a new intraoperative botulinum toxin study. And so there's two studies listed here, the BOTAF and then the NOVA study. Specifically evaluating the use of botulinum toxin in the epicardial fat pads intraoperatively to see if that reduces post-op AFib. Some other interventions that I think have come up but simply don't have or have a lack of consistent benefit or concern for side effects. Sotalol, steroids, statins, NSAIDs, they've all been studied in different ways but don't have the right consistent evidence to determine use at the moment. Colchicine has had mixed results, and the side effects, GI side effects specifically, may be significant. Fish oil, vitamin D, also evaluated, but don't have enough consistent evidence to recommend. There is new evidence looking at epicardial gel, a hydrogel, kind of encapsulating the heart at the time of surgery so that you reduce some of the side effects of systemic amiodarone in the ICU. Still don't have enough data for that to recommend consistently. And then lastly, there's interesting evidence for EP examination, looking at arrhythmogenic substrates to see who is at risk for AFib versus who is not. But again, still in investigation and not enough data to recommend throughout the guidelines right yet. That's the end of the presentation. I'll open up to questions. Okay, thank you.
Our next speaker is going to be Darlene St. Victor, who is going to go over hypertension and CABG.
Good morning, everyone. Thank you for having me here. Let's discuss everyone's favorite topic, which is hypertension. This presentation aims at revealing the epidemiology, pathophysiologic mechanisms, and preventative and therapeutic measures for this condition. In addition, reviewing best practices for enhancing patient prognosis. The main objectives of this presentation is to provide a detailed definition of systemic hypertension in the context of CABG, highlight its prevalence and associated risks. Additionally, I will discuss the physiologic mechanisms and patterns of hypertension observed during and after CABG procedures. Finally, we will review management strategies and explore clinical implication for best practice. Hypertension is a common and critical complication of patients undergoing CABG. It contributes to increased surgical and postoperative risks, including myocardial infarction and stroke, and can compromise graft integrity. It can be associated with pre-existing hypertension, stress during surgery, and hormonal changes, especially with activation of the renin-angiotensin system. Effective management of this condition requires a multidisciplinary approach involving surgeons, anesthesiologists, and critical care specialists. By understanding the risk factors, mechanisms, and management strategies, we can improve patient outcomes and enhance procedural safety. Now we're going to discuss the prevalence. Hypertension is a common complication affecting 30 to 60% of patients. Its occurrence is higher than any other cardiac surgery due to complex interplay of systemic vascular resistance, hormonal activation, and surgical stressors. The peak incidence in the immediate post-op period, particularly the first 6 hours in the ICU when patients are most vulnerable. Graphical data shows the distribution of hypertension across surgical phases, highlighting the need for targeted monitoring. Recognizing this prevalence allows us to prioritize timely interventions to reduce associated risks such as bleeding and myocardial infarction. Several factors contribute to the risk. Preoperative hypertension and elevated baseline blood pressure is one of the most significant predictors. Anatomical consideration, greater than 50% obstruction of the left main coronary, elevated dopamine, and increased angiotensin activity. Understanding these factors enables better stratification of patients and guides clinicians in implementing preventive strategies such as maintaining antihypertensive therapy preoperatively. Okay, all right. Sorry. The physiological mechanism underlying hypertension in CABG patients are multifactorial, increased systemic vascular resistance, again, angiotensin as the primary contributor, elevated levels of catecholamines and serotonin during intubation, sternotomy, cardiopulmonary bypass exacerbate hypertensive responses. Hypothermia during cardiopulmonary bypass triggers vascular constriction and hormonal fluctuation, compounding the hypertensive risk. These mechanisms highlight the need for targeted interventions to address specific triggers of hypertension. Hypertension during CABG typically follows distinct hemodynamic patterns. Postoperatively, persistent elevations are common. Understanding these patterns will help clinicians anticipate and address hypertension effectively. In the postoperative period, hypertension peaks within the first 6 hours in the ICU. Pain, hyperthermia, sedation gaps are significant contributors to these hypertensive episodes. If not adequately managed, such episodes can lead to severe complications, including stroke, myocardial infarction, and graft failure. Management typically involves the use of vasodilators and optimized sedation protocols to stabilize the blood pressures. Postoperative monitoring plays a pivotal role in ensuring hemodynamic stability after CABG. Continuous arterial pressure monitoring in the ICU is crucial for detecting rapid changes in blood pressures, which are common again right after. Short-acting vasodilators, such as IV nitro, are frequently used. Identifying and addressing triggers, again, for hypertension, such as pain. These factors, if not managed, can lead to significant complication, myocardial occlusion, myocardial infarction, cerebrovascular events. Ensuring proper postoperative hemodynamic monitoring also allows healthcare providers to intervene promptly, reducing the risk of long-term complication and improving recovery time. So there's a range of pharmacological agents utilized to manage systemic hypertension and CABG. IV nitro and nitroglycerins are commonly employed to reduce vascular resistance and achieve a rapid blood pressure control. Beta blockers are used to manage myocardial oxygen demand, while ketanserin provides stable blood pressure control without causing reflex tachycardia, making it an effective choice in the CABG setting. Ketanserin is a unique antihypertensive agent. It plays a critical role in managing hypertension during CABG. It works by blocking the alpha-adrenergic and serotonin receptors, providing stable blood pressure control. This agent also enhances peripheral perfusion and diuresis with minimal rebound effects following discontinuation, making it an invaluable tool in intraoperative and postoperative hypertension management. During CABG, effective blood pressure management is crucial for achieving successful surgical outcomes. Elevated blood pressure can increase the risk of excessive bleeding at suture lines, which complicates the surgical process and increases the risk of postoperative complication. Additionally, stable blood pressure helps reduce myocardial wall tension, which in turn lowers our oxygen demand on the heart, providing a protective effect during surgery. These measures also enhance the surgeon's ability to visualize the operative field, particularly during graft placement, thereby improving the precision of the procedure and maintaining adequate blood pressure throughout the surgery. Contributes to better intraoperative stability and reduces the risk of adverse events such as arrhythmias and ischemia. Another important yet often overlooked factor is blood pressure variability in CABG outcomes. Long-term blood pressure variability is associated with an increased risk of severe complication, including stroke, renal failure, and mortality. High variability often reflects unstable vascular compliance and may indicate underlying endothelial dysfunction. Such instability can lead to inconsistent perfusion of vital organs, worsening patient outcomes. Preoperative stabilization of blood pressure is essential to minimize variability and protect against these risks. Implementing tailored blood pressure stabilization protocols include adjusting medication and adjusting modifiable risk factors, which help improve both short-term and long-term outcomes. Clinical guidelines. Adhering to these guidelines is essential for managing hypertension effectively. One of the fundamental recommendations is to continue preoperative antihypertensive therapy, which helps maintain hemodynamic stability and reduces variability in surgery. During the intraoperative phase, the use of vasodilators is recommended to control the acute rises in blood pressure, preventing damage to the grafts or complication or related to excessive bleeding. Close post-op monitoring for blood pressure variability is also emphasized. Guidelines suggest that management strategies must be tailored to the specific needs of each patient, taking into account their medical history, comorbidities, and intraoperative course. This individualized approach ensures more effective and safer outcomes. The management of systemic hypertension in CABG patients presents numerous challenges. Drug interaction and side effects complicate selection of pharmacological agents. For instance, while vasodilators are effective, they may cause hypotension if not carefully dosed, potentially compromising organ perfusion. Balancing the need for blood pressure control with the heart's oxygen demand is another significant challenge, particularly in patients with pre-existing cardiovascular conditions. Furthermore, variability in individual patient responses to antihypertensive therapy requires careful adjustment and monitoring. These challenges highlight the necessity of the multidisciplinary team approach involving the surgeons, anesthesiologists, cardiologists, the ICU staff to achieve optimal outcomes. The future of hypertension management in CABG focuses on personalized medicine and technological advancement. Research on individualized blood pressure management protocols aims to tailor treatment based on each patient's unique hemodynamic profile and risk factors. Additionally, the development of targeted pharmacological agents, such as those designed to modulate specific components of the renin-angiotensin or catecholamines pathway, could offer more precise control of hypertension with fewer side effects. Innovations in real-time hemodynamic monitoring, including advanced arterial waveform analysis and wearable technologies, hold promise for improving intraoperative and postoperative management. In conclusion, systemic hypertension is a critical complication of CABG that requires careful attention throughout the perioperative period. Its high prevalence in association with adverse outcomes such as myocardial infarction, stroke, and graft failure underscore the importance of early recognition and effective management. Pharmacological interventions include the use of agents like ketosarin have shown promise to providing stable blood pressure control without significant side effects. Furthermore, ongoing research and innovation in monitoring and individualized care strategies are paving the way for improved outcomes. By adopting a holistic and multidisciplinary approach, healthcare providers can ensure safety and recovery for patients undergoing CABG. And it's very interesting that when you do the research, not so much people focus on hypertension prior to surgery. So I think there's a lot of more improvement we can help with our patients. Thank you.
Thank you, Darlene, for that very informative presentation. Our last speaker for today for the perioperative program is Dr. Leila Husanian, who's going to go over pressors and inotropes.
So I have no conflicts of interest, but I'm going to be speaking to you as a physician who over the past 20 years, I've trained and worked at many different settings, from large academic centers to mid-sized centers to now I'm in a private practice hospital. So I've treated hemodynamics in every different way based on the institution or the surgeon. Everyone likes something different. So as an anesthesiologist or intensivist, when I go to a new hospital, there's already established practice patterns. There's an established culture that is often very difficult to change, so I've always had to adapt. I've adapted many times, and gradually I can bring my experience and practice style to the forefront of wherever I go. But I've also learned that there's many ways to safely skin a cat. I'm going to show you papers and different types of, and tell you side effects, but there's a lot of different ways of bringing blood pressure up that's effective, and there's a lot of ways of improving cardiac output that are effective. And sometimes it's just based on the patient. Patients are sometimes more sensitive to one drug or another, even though technically when you look at the data, one should be better than the other. So, and basically, so there is no real perfect formula, but at least this gives you some guidelines as to what these drugs are and the basics of how to use them. So after cardiac surgery, the vast majority of patients will require pressors, inotropes, or a combination of both. This is due to systemic vasoplegia and cardiac stunning that takes place during heart surgery, regardless of if it's valve surgery, bypass surgery, on pump, off pump, or a combination of everything. Obviously, the magnitude of the pressors and inotropes you're going to need is going to depend greatly on the preoperative function of the heart and the type of surgery. However, all will likely rely on them for at least the immediate postoperative period. Prompt hemodynamic support is essential to reduce the risk of developing multi-organ dysfunction and to preserve cellular metabolism. Pharmacological therapy with the use of pressors and inotropes increases cardiac output. It alters our systemic vascular resistance, which all improve hemodynamic stability and tissue perfusion and allows us to avoid systemic and myocardial ischemia. What I want for you to be able to do is to move between hospitals or even take care of different surgeons' patients and work within their preferences and understand what's safe and what's not safe, and to be able to guide the next steps when the current strategy is not working within the limitations of whatever center or surgeon you're working with. This is a multi-center, I know it's very busy, but it's a multi-center observational study, and it looked at 51,000 non-emergent cardiac cases in 29 different hospitals, and there was 611 different attending anesthesiologists. Almost 53% of these patients received at least one inotrope intra-op. 42% of them received epi, 12% milrinone, about 4% dobutamine, and 1% dopamine. But variation in the inotrope that was used was 70% attributable to the patient, 22% to the institution, and 6.8% to the attending anesthesiologist. So there's a large percentage that has nothing to do with the patient, what you're using, but it has to do with what's the institution or who's the doctor who's starting it. So while presenting patients, their comorbidities and characteristics are related to the variability in inotrope use during cardiac surgery with cardiopulmonary bypass, the institution where surgery is performed and the anesthesiologist caring for the patient are also factors with increased variability in inotrope usage. Factors that were most strongly associated with increased likelihood of inotrope were institutional, if the hospital was associated with a medical school, so most likely having a residency, patients with heart failure, pulmonary circulatory disorders, patients who are on loop diuretics at home, digoxin used as a home medication, as well as African American race. There are surgeons and anesthesiologists, that just prefer to come off on one dopamine or dobutamine, for example. And it doesn't matter if the cardiac output looks good on the echo, they just believe that you should always come off of these drugs. And it's as if it failed once or twice, they didn't come off, even though the echo looked great, and then they started to have some low cardiac output in the ICU, and then they create these standards of care, which are really not based on any medication, not based on any science, but that ends up becoming their personal formula for success, and we kind of go with it. But we do have to realize that a lot of these drugs have side effects, so it's important for us to be able to kind of direct a little bit more and push care so that we're relying more than 70% on what the patient needs and less on what the institution wants or what the anesthesiologist or surgeon wants. So the first drug, or actually we're going to talk about these inotropes and pressors. These are the most commonly used ones. A couple of them that I included here are not used in the United States. They're not FDA approved, but I wasn't sure if we had
non-US people practicing in the US, but I think everyone practices no, you guys don't practice in the US, do you? Probably not. So I included those two, but I've never actually used them. I probably should have included angiotensin too, which I didn't, and I realized that at the end. So let's start with dobutamine. The mechanism of action, it's a synthetic catecholamine that primarily stimulates beta-1 adrenergic receptors. So the activation of G protein-coupled beta-1 receptors in cardiac tissue cause an increase in CAMP and protein kinase A, resulting in an increase in intracellular calcium. This eventually results in a positive chronotropic and inotropic response, and it increases myocardial contractility. So you have an increase in heart rate and you have an increase in cardiac output. Keep in mind, this also results in an increased myocardial oxygen consumption. So heart rate is actually one of the greatest contributors to myocardial oxygen consumption, and secondary to that is an increase in contractility. There is a weak beta-2 receptor agonist, which results in vascular smooth muscle dilation. However, I don't see significant amounts of hypotension with this drug. And I think it's because there is also an alpha-1 receptor agonist, which most likely negates much of that. So indication used for acute heart failure, low cardiac output, cardiogenic shock, post-cardiac surgery. I've listed the dose that it's initiated at, maximum dose of 40 mics per kg per minute. I've never gone that high. Generally, when you're going up that high, you're adding other agents. Advantages, it increases cardiac output. I've written here without significantly increasing heart rate. There are other drugs that do increase it a lot more than this does. It is a strong inotrope. It works very quickly. But yes, it can cause tachycardia. It increases myocardial oxygen demand. So on a patient with ischemia who hasn't been revascularized, you have to be very careful. If you're causing this really high increase in heart rate, you may actually worsen the ischemia. You can have hypersensitivity and you can get tachyarrhythmias. Next, we have milrinone. It's a phosphodiesterase 3 inhibitor. It hydrolyzes CAMP, so you have increased CAMP levels, which enhances calcium influx into the heart muscle, leading to increased contractility and vasodilation. These receptors are also found in vascular smooth muscle, which is why you have some problems with hypotension using this drug. This is used in acute decompensated heart failure and low cardiac output syndromes. It is also frequently used in peds cardiac surgery. There is a bolus that technically you need to start because it takes a while to get to the level that you need for milrinone. The bolus, though, is often not used because you can have significant hypotension from the bolus. The continuous infusion rate is anywhere from 0.125 to 0.75 mics per kg per minute. Inhalation of a 5 milligram just inhaled dose through the ET tube is also, or as a nebulizer, is also an option. But again, it's not very controlled. It gives you kind of this burst of inotropic support and then it wears off. It's not easy to predict. Advantages, increases cardiac output, reduces pulmonary artery pressure, and it has a vasodilatory effect, which reduces afterload. Side effects, risk of hypertension, may cause arrhythmias, particularly ventricular arrhythmias and severe renal dysfunction. It's contraindicated, but I actually wouldn't say contraindicated. Careful use in severe renal dysfunction due to it's broken down by the kidneys and it just kind of stays in a patient. The duration of action is a lot longer in a patient with renal dysfunction, so you can see worsening hypotension. So between milrinone and dobutamine, there are certain people that are very much in favor of one or the other. I would say in general, and there's some institutions that really favor one more than the other. I can tell you that in the almost 10 years I was at Mount Sinai, on Mount Sinai, the Upper East Side campus. So we never used dobutamine, never used dobutamine. And dobutamine was a very basic drug that I had used at Columbia, University of Chicago, but they just hated it. They thought that the tachyarrhythmias were worse with it. But subsequent to that, we went to Loyola, and now I'm at Mainline, and that's our primary inotrope to go to. Now, the nice things about dobutamine, it works really quickly. You start it, it starts to work. You can see your cardiac output starts to go up. Your heart rate, there is some increase in your heart rate. I wouldn't say it's any different than milrinone, and there hasn't really been shown to be much of a difference in terms of the two of them, in terms of arrhythmias, but it works fast. It doesn't cause that hypotension, but it was not used at all at Sinai. It's really strange. So milrinone, I generally reserve milrinone for patients with right heart dysfunction and with pulmonary hypertension because it relaxes the pulmonary arterial vascular, it decreases your PA pressures. And for patients with right heart dysfunction, that's very favorable because you're getting the inotrope and you're getting the decrease in afterload. So the combination of two for those patients is really beneficial. So I reserve it on those patients because there is the potential for the hypotension, and in patients with renal dysfunction, you have to be careful, but a lot of these patients with right heart dysfunction, pulmonary hypertension, have some form of CKD, but we're still using it. I would say that even though milrinone, yes, it does cause vasodilation, sometimes you'll start milrinone and actually you'll see an increase in your blood pressure. And that happens is if your hypotension is solely due to heart failure. So if it has nothing to do with vasoplegia, so your patient coming out, it's not vasoplegia after heart surgery, it's just purely stunning of the myocardium, your EF is low, the heart is done, and you start the milrinone, you will often see actually the pressure go up because your cardiac output is going up and you're perfusing better, you're resolving your acidosis. So don't just dismiss milrinone because the patient is hypotensive if it's not due to, if your SVR is high because they're in cardiogenic shock and you start the milrinone, you're not going to see necessarily that drop in blood pressure. You'll see it more as if you have a low SVR already, so you're in a combination of a cardiogenic and a vasodilatory shock. So don't dismiss milrinone, but a lot of people don't like to start it because they're just worried about that hypotension. Enoxamine, again, it's not a drug that I've ever used. It's very similar to milrinone in terms of working as a phosphodiesterase 3 inhibitor. It also increases intracellular calcium. It's used in low cardiac output states. I've listed the dosages. Again, you can have problems with hypotension, but it does increase cardiac output and decreases pulmonary arterial pressure. It's not FDA approved. There is an oral formulation of this, though, so I wonder if in the future it may become something that we use for patients with chronic heart failure. So this is a New England Journal of Medicine article published in 2021, milrinone as compared with dobutamine in the treatment of cardiogenic shock. It's a single-center, double-blinded, randomized controlled trial, which includes 192 patients admitted to ICUs with cardiogenic shock and randomized the patient to either receive dobutamine or milrinone. And there was no difference in hospital mortality, resuscitated cardiac arrest, the need for cardiac transplantation, or mechanical circulatory support, non-fatal MIs, strokes, or renal replacement therapy. So we have to really kind of be cautious about using this. It's a pretty small study, but it was published in the New England Journal. But it does show that it's really, you can choose either, and there isn't necessarily one that's better than the other. And again, you should be comfortable using either one, and maybe if you see a patient that has a higher SVR and it is very much a cardiogenic problem or has pulmonary hypertension or right heart failure, try to maybe push the milrinone forward. But again, you don't get, without the bolus, it's going to take a little time to start to see the increase in cardiac output, whereas the dobutamine, you just get the results very fast. So it's a little bit of a kind of easier drug to use and an easier drug to wean. So this is another paper. It was published in 2023 in the Canadian Journal of Anesthesia. It's a it's a review and meta-analysis of papers regarding the use of milrinone and dobutamine in cardiac surgery. 5 different studies looked at hemodynamic parameters of both drugs and found mean arterial pressure. There was no difference between milrinone and dobutamine at baseline or 12-hour follow-up. Dobutamine, however, did have a significant increase in MAP, more than milrinone after the first measurement, after the initiation of the infusion, which is exactly what I've said. It works a lot faster. Dobutamine did cause a significantly higher heart rate than milrinone did at first and in follow-up time points. In practice, I don't necessarily think I see that significant of a difference. Do you guys agree, or you think dobutamine is increases a little more. I don't see so much of a difference. Yeah, I don't tend to see that much. And there's a lot of papers that show that there isn't much of a difference in terms of arrhythmias of either one of the two. The cardiac index was not significantly different, except for it was higher in the first measurement with dobutamine. Again, it works really quick. Figure A does look at new arrhythmias, and it was a little higher in the dobutamine group, but when they looked back at those studies, there was a lot of bias. So again, dobutamine works faster, relatively similar in their arrhythmia profile, and be careful when you use milrinone. You may need something, if you're not going to bolus, you may need something to work. If you need something to work faster, you may have to transition to it. You might have to start another agent like dobutamine or an epinephrine first, and then once you get to a level where you feel like things are working with the milrinone, wean off the other one. But it's better for RV failure and pulmonary hypertension, and you can use it in patients with acute kidney injury and chronic kidney disease. Just use the lower doses. Levosimendan is a class of drug called a calcium sensitizer. It's not available in the US. I've never used it. It has both peripheral vasodilatory effects and enhances myocardial contractility mediated through vascular smooth muscle potassium channel binding and cardiac myofilament calcium sensitization by calcium-dependent troponin C binding. It has similar hemodynamic effects as milrinone. The thing about this drug is that the effects, there's a metabolite, and so it can act for a week, potentially, up to, they said like 80, 90 hours, up to a week. So it's not something that once you turn off, it's like out of your system. And so there are countries in Europe that use it. But the data, I think probably the reason that they didn't get approved is that there wasn't really any significant benefit that was shown using levosimendan with the other inotropes that we have. This is a meta-analysis of this is actually a meta-analysis that was published in 2020, and it's of 27 randomized controlled trials, about 3,200 patients, and the patients received levosimendan versus another inotrope. They did actually show a reduction in mortality using it. They showed less low cardiac output syndrome, AKI, and RRT, but it still hasn't been approved in the US. So norepinephrine is actually advocated as first line in it's kind of more recently being advocated as first line for cardiogenic shock. It is already actually first line for septic shock. So it is primarily acts on alpha-1 adrenergic receptors causing vasoconstriction. It also has some beta-1 activity, increasing heart rate and contractility, and minimal beta-2 activity. Again, first line for septic shock, and it's now being advocated as first line for cardiogenic shock. Those are the doses that you can use. It's a strong vasopressor. It improves SVR and blood pressure. It also can cause arrhythmia. It does have some beta properties. It can also increase myocardial oxygen demand. It can worsen peripheral ischemia, cause skin necrosis, and digital ischemia. I'm sure everyone has seen this on patients with high doses of these pressors. You can have definitely tips of fingers and becoming ischemic. So you really need to make sure that when you are treating a patient with a vasopressor, and this obviously isn't a pure vasopressor, so you do have beta effects, so you are kind of protected. That's why it's a nice drug to start, because you have the beta and the alpha, but the alpha is primary. You do have, you're kind of hedging your bets that there's a dual problem, but you really do need to make sure that you correct your hypovolemia, because to just start a pressor on a patient when you're dealing with hypovolemia or cardiogenic, or if you're dealing with also cardiogenic shock, that's not going to give you the outcome that you want. You have to make sure that you're kind of dealing with hypotension straight on based on why that patient is hypotension. And often after heart surgery, it is multifactorial. It's not just one thing. And that's the nice thing about norepinephrine is that it will give you kind of some increase in cardiac output plus the pressor. Epinephrine. So epinephrine is a potent adrenergic agonist that stimulates alpha-1, beta-1, is the primary actual stimulation, and beta-2 receptors. So you have the vasoconstriction, the increase in heart rate and contractility, and you have smooth muscle dilation, bronchodilation, which is also used in a patient with severe asthma. It's used also in anaphylactic shock, cardiac arrest, cardiogenic, vasoplegic, septic shock. It's kind of this wonder drug because it does everything. Not anything that well, but it does everything. So those are the doses. I've listed them there. It's a potent vasopressor and inotrope. It can also increase myocardial oxygen demand as well as delivery. It can cause ischemia, increase in lactate, skin necrosis, and digital ischemia. So the thing about epinephrine, and this is, so instead of using dobutamine at Mount Sinai, we used epinephrine as if there was no tomorrow. And I remember when I first went there, I was very frustrated because I always wanted to kind of treat your, I wanted to have a separate inotrope and I wanted to have a separate pressor so that you could wean each one kind of separately. And instead with epinephrine, you get both things at the same time. And so sometimes it makes it frustrating because you feel like the patient only needs the inotrope and not the pressor anymore, and you're giving both drugs, and you can't separate it out. But that was loved at Sinai, and I used it for all these years. Then I go to Loyola, and they don't use it. And at Mainline, one of the senior surgeons, he's like, "Why would you ever use that disgusting drug? The only time you should ever use epinephrine is if there's a bear chasing you and you're going to die." It's only for that. So basically saying that you should only use epinephrine if literally the patient is dying, and that's it. But for 10 years, I used it every single day on almost every single patient that came out after a mitral valve repair with David Adams. And one of the things now that I look back on it, they shifted my practice eventually after so many times of starting vasopressin or dobutamine wasn't even used, but starting milrinone and having the hypotension. They're like, "Why are you making your life difficult? Just start the epi." But the epinephrine, I can tell you now, it increases your lactate. It increases your lactate, and when you have that increase in lactate, you're pushed to start to give more fluid, and you're pushed to give more fluid, and you're pushed to give more fluid. And then the patient's a Michelin man at the end of 2 days, and now you're working to diurese the patient. So I do believe that there's a higher lactic acidosis. I do still find it frustrating that you cannot separately titrate in terms of the pressor and inotrope. And in our practice right now, we're not using it. And if I have a choice, which sometimes I don't, I would not use epinephrine as routinely as I did for 10 years. And those are the reasons. There is really a increase. It's like your lactate can't get below 2 or 3. You kind of get stuck at that unless you drown them with fluid. So it is, though, a great drug when you're not sure what's going on because it's doing a little bit of everything. And so it's useful for that, but it's kind of a stupid drug that does everything, and you're just kind of throwing the kitchen sink and you're not sure where you're going. But for the very, very sick patient, it's useful. This is a trial. It's a multi-center randomized controlled trial of 9 French ICUs. 57 patients were randomized, not a big study. Cardiogenic shock, they looked at epinephrine versus norepinephrine for cardiogenic shock after an acute myocardial infarction. So cardiogenic shock, these patients, it wasn't due to surgery, it was due to an MI, and these patients had to be successfully revascularized with a stent to be randomized into this trial. They had to have a systolic blood pressure less than 90, an index less than 2.2, an EF of less than 40% on echo, evidence of organ malperfusion, and they had to have a PA catheter. So I think that's probably why the study is kind of small. It's only 57 patients. And epi's in red, epi's in blue and norepi's in red. And basically, they found not much of a difference in MAP, cardiac index, heart rate, or stroke volume, but they did find a lot more refractory shock in the epi group versus the norepi group. And that's why the study was terminated early, because they had a significant increase in refractory shock which is basically having cardiac dysfunction, elevated lactate, some organ dysfunction, or sustained hypotension after initiation of the drug. So their conclusion was cardiogenic shock secondary to an acute MI. There's a similar effect on both arterial pressure and cardiac index, but a higher incidence of refractory shock in the epi group, and epi was associated with an increase in heart rate, lactate, and prolonged acidosis. Dopamine is a precursor of norepinephrine and has dose-dependent effects. At low dose, it stimulates dopamine receptors, causing vasodilation. At moderate doses, it stimulates beta-1 receptors, increasing contractility and heart rate. And at high doses, it stimulates alpha receptors, causing vasoconstriction. It can be used in shock. Previously, it was first line in septic shock. Very previously, I mean, it was a while ago. It's been levo for a while. Those are the doses I've listed. Tachycardia and arrhythmias. I would say that this is the agent that causes the most tachycardia. If I have a patient with bradycardia, this is the drug that I'm going to start. It can exacerbate myocardial ischemia in patients, mostly because of the tachycardias. So there is not consistent data to show that dopamine protects from renal dysfunction after heart surgery. I think it's a terrible drug. I don't like it. I don't use it. It's usually used by more senior surgeons. It's kind of their first go-to agent, and historically it was a first go-to agent, but now we have more data to show that other agents are better to go to as first line. And the reality is for me, I use this as mostly for heart rate, and that's it. But there are some surgeons who love it, and I start it, but I try and stop it as soon as I possibly can. This is another trial. So basically, it's a multi-center randomized ICU trial of, This trial, it's comparison of dopamine versus norepinephrine in circulatory shock after cardiac surgery, a randomized controlled trial. So when shock persisted, they started either norepi or they started dopamine, and if shock still persisted after 20 mics per kg per minute of the dopamine or 0.2 mics per kg per minute of the norepinephrine, then epi or vaso was added. They looked at 100 patients. And they saw that 25% of patients in the dopamine group had tachyarrhythmias versus only 2% in the norepinephrine group. The dopamine group also required more frequent addition of additional vasopressors, but there was no difference in mortality. Vasopressin, arginine vasopressin is an endogenous hormone. It exerts its cardiovascular effects through the activation of G protein-coupled receptors, V1 in smooth muscle, V2 in the renal collecting tubules. Activation of V1A receptors on vascular smooth muscle causes an increase in cytosolic calcium and resulting vasoconstriction, and the V2 receptor activation leads to water retention via the distal convoluted tubules. Vasopressin effects in cardiogenic shock are mostly just due to an increase in SVR. You have a very limited effect on cardiac output, so you really should use this as a pure pressor. Don't use this, there's not really any inotropic effect. There is data, though, to show that vasopressin vasoconstriction may be selective and affects the systemic and not the pulmonary arterial system. So this is exceptionally important in patients with pulmonary hypertension and right heart failure. The combination of milrinone and vasopressin is ideal in these patients because you have milrinone causing the inotropy for the RV, you decrease your PA pressures, okay, so because it causes the vasodilation. With the vasopressin, with the hypotension that you can get from the milrinone, this causes the systemic increase in blood pressure, but it doesn't cause an increase in your PA pressure, so it's not affecting your pulmonary arterial system. So really, it's like an ideal drug for that. It's also deemed to be a second-line agent in terms of septic shock. And there's more and more research saying that you should start your second-line agent a lot faster. You shouldn't wait until you're on very high doses of the first-line agent until you start the second-line agent. So this is a prospective double-blind trial of patients in vasoplegic shock after cardiac surgery. So these are patients with a MAP less than 65, resistant to fluid challenges, and an index of greater than 2.2 after cardiac surgery. This 300 patient were either treated with vaso of 0.01 to 0.06 versus norepinephrine of 10 to 60 mics per minute. They found a lower occurrence of AFib in the vasopressin group, 63 versus 82%. And they found no difference, because this does come up. Does it cause more mesenteric ischemia? Do you have more ischemic issues with vasopressin versus norepinephrine? But in this study, they didn't find any additional higher rates of digital ischemia, mesenteric ischemia, hyponatremia, or MIs. They also found a decrease in the primary endpoint, which was mortality or severe complications within 30 days, and those severe complications included stroke, greater than 48 hours of mechanical ventilation, deep sternal wound infections, re-op or acute renal failure. In the vasopressin group, it was 32% versus 49% in the norepinephrine group. One of the things I just want to kind of put out there, how many people wean vaso from 0.01 to 0.02 to 0.03 up, and how high do you guys go? Because I am not very comfortable with vasopressin at 0.1. I feel like that should be basically, you're in full massive cardiogenic shock and you should be going on mechanical circulatory support. But I feel like you start to see more of the side effects with the ischemia, which obviously makes sense. You're on higher doses of pressors, but I generally tend to avoid those doses. And we do wean by 0.01 in our institution. Previously, I'd only do 0.02, 0.04, and rarely go any higher than that. Does anyone have a different type of practice? You wean 0.01 at a time? Yeah? Because back when vaso was more, it was maybe 10, 15 years ago, it was like either you were on or off. And instead, I see a lot of titration, and I feel like you can see a significant difference with the bit of titration that you do, and it is better to titrate than to have it all on or all off. Methylene blue. Methylene blue is interesting. It is usually something that we use kind of third, fourth line after you haven't been able to get the blood pressure up with your levo, your epi, your vaso, and now you're still struggling. You've treated the volume issue, you've treated the cardiogenic shock, and you're just really very vasoplegic. So methylene blue inhibits the action of monoamine oxidase A, an enzyme responsible for breaking down serotonin in the brain. So you should not give these to patients taking serotonergic psych meds. So that's like a big thing that I want everyone to know. Do not give it to those patients. So you can end up getting, if you do have a serotonin syndrome, there's a brain toxicity which causes tremors, seizures, fevers, hypertension, agitation, muscle rigidity. So please make sure you do not give it to any patients that are on SSRIs, SNRIs, tricyclic TCAs, MAOIs. Just don't use it in any of those. We're going to talk about B12 next, and you can use that instead. But so it's basically the mechanism of action is it inhibits nitric oxide synthase and guanylene cyclase, reducing nitric oxide production. So in vasodilatory shock, there's just a lot of nitric oxide out in the system, and so this is supposed to kind of reduce that and to improve vasomotor tone. There is some antioxidant properties as well, so you can use it in septic shock, vasoplegic shock. There's a dose that you give, 1 to 2 mg per kg IV over 30 minutes, and there's a max dose of 4 mg per kg per day. Again, the data shows you that your blood pressure goes up. It does a good job with that. How long it lasts, it's very variable depending on the patient, but it makes the blood pressure go up. Now, has it shown to have any long-term benefits? No, but it does help you to come off of some of your pressors. And if your vasoplegia is just temporary, you're just having some problems, the patient had a really big SIRS response to surgery, it can get you over that hump. Hydroxycobalamin, it works in a very similar type of way. It also inhibits nitric oxide vasodilation. It's primarily used in cyanide poisoning and shock states. This drug is very expensive for some reason. I don't know why. It can also be used if you can't use, the only time we use this drug, just because it's so expensive, is if we are contraindicated to use methylene blue. I'd say that there have been patients that we've given methylene blue to who their blood pressure didn't go up, and then we got the approval for B12, and we did see improvement. I'm not sure why. I haven't seen great studies comparing the two, but it does help to increase your blood pressure again, and we don't really have data in terms of whether it does anything more than just that. It does cause some alterations in some of your labs, and one other thing to say about methylene blue, it does, for that temporary period of time, your pulse ox is not going to work very effectively, so just take note of that and use a blood gas instead. So final remarks. So inotropes are essential in the management of patients with cardiovascular compromise, particularly those with low cardiac output and shock. You really need to take an individual approach to patients. Some patients are just more sensitive to certain agents than others, and I think you have to be very vocal about telling the intensivist or the surgeon, hey, I know you don't really want to start vaso, but the patient's just not sensitive to this norepinephrine. Let's try it and let's see what happens. And it's also important not to wait too long to start these drugs. Low blood pressure has been shown to cause organ injury, lactic acidosis. You really need to start very early before you start to have the low perfusion syndromes. So start your drugs early, titrate the drugs. Generally, we target MAPs of 65, but if you have a patient with severe hypertension that's uncontrolled, you may have to target a higher blood pressure to get well perfused. You'll see patients with chronic hypertension who you're trying to target a MAP of 65 and you can't get them to pee. You increase the MAP and suddenly they're perfusing great. So you really have to kind of keep the surgeon, keep the intensivist in the loop as to how the patient is acting with these drugs that the patient is on, and kind of push them to titrate, push them to add or subtract meds, depending on what you see at the bedside and how you see the patient respond. Some patients respond great to one drug rather than the other, and move to wean the one, quickly take off the drug that they're not that responsive to. Because as you can see, the data is not great to support one or the other, and as long as you know the side effects of the drugs, what each one can be used for, and you have a really good kind of understanding of the drugs, it's important for whoever's at the bedside to really be sending the message that he doesn't like this drug, he likes this drug, I think we need a little more cardiac output. Should we start the secondary drug sooner than continuing to escalate on a drug that doesn't work? So I think it's really important to have those discussions and to have them continuously throughout the day, not just when you round with the patient in the morning, because things are constantly changing, and to get everyone back to the bedside to say, hey, this management strategy is not working, I still have a low SVR, or my cardiac index is still very low, let's change the approach. And as long as you feel comfortable with the drugs, it's very easy to, and you're comfortable understanding the side effects, it's very easy to kind of mix and match everything, and don't get too stuck with the institutional preferences and try to advocate for trying different drugs when the institutional preferences are not working. Thank you.
Thank you. Does anyone have any questions for any of our speakers that presented today? All right, that concludes our perioperative program. Thank you. I also want to thank all of the speakers for wonderful presentations today and yesterday, and everyone enjoy the rest of their day and the rest of the conference.